You mentioned that you found out for certain you had endometriosis with your surgery, and yeah, validating those symptoms, it's a very real thing that patients need.
My mum probably has it too because she's always had, like I've got adenomyosis as well, and she's always had heavy, like she was fainting, she was like had iron deficiency problems, but that's the person who then teaches you what is or isn't normal.
Yes, if you're told the surgery is going to fix everything, then you should question that.
I'm Jason Mak. I'm a local gynaecologist, sonologist on the Central Coast. And I'll let Helen and Kelly introduce themselves, and then I'll introduce you guys.
Hi, I'm Helen Manning. I'm an obstetrician and gynaecologist on the coast as well. I'm trained in the UK and went to America for 5 years and then came to Australia in 2020, where I've been practicing as a general obstetrician and gynaecologist, focusing more on gynecology now.
Yes, perfect. I'm Kelly Hankins. I am a specialist gynecologist and obstetrician on the coast as well. I've been working on the coast since 2014. I do some obstetrics and am probably a little bit more focused on the gynecology surgery, as well as doing a little bit of chronic pelvic pain work.
So we are a group of local gynecologists that do endometriosis surgery. And we've got Beck, Gillian and Chloe, who have really kindly agreed to join us for this roundtable discussion. And I guess the trigger for it was, there was a Four Corners report called SCARred that aired Monday last week. And it raised a lot of questions. So I've been, I don't know about you, Helen and Kelly, but I've been getting a lot of phone calls and just in consultations. People have got a lot of very reasonable concerns and questions that were raised by that story. It was quite provocative, pretty scary to watch. And it's caused a big storm in gynecology behind the scenes. There's lots of discussion going on about it and what it means and what the implications are. But I think most of all, there has been a bit of a vacuum of people kind of explaining some of the nuance around endometriosis surgery, histopathology, staging, repeat surgery, removing people's organs or ripping out reproductive organs. As a kind of some of it was quite provocative, but we wanted to help answer some questions that it might have provoked. So first of all, thank you guys so much for joining us, and you can feel free to tell us a bit about yourselves.
Yeah, I'm a patient of Dr Mak's. Actually, I had my first excision surgery with him a month ago. And I got diagnosed about a year ago-ish from now.
Can I ask, was your path pretty long before you got to Jason?
I think it's fairly short. It's been about 2 years since I started looking into what was causing all my symptoms, or when my symptoms got a lot worse. But I suppose technically, like, I've had what I now know is a more painful period than is normal since I was a teenager. So, but I started looking into it when I started getting bladder and more chronic pelvic pain was 2 years ago. And then fortunately, a friend of mine saw Dr Mak's Endo event last March, and we went to that, and then so that helped speed things up.
And you won the Lucky Door Prize, didn't you?
Oh, did you? I did win the Lucky Door Prize. We were we're at the front too, I think, because we were coming in late, and someone was like, "Come sit at the front," and we were like, "Oh no!" And then I won the prize anyway, so it made it worth it.
Endometriosis came into my life very late on, obviously in my 50s. Only found out that I had it when I had a colonoscopy. They took some tissue, had it tested, and told me I had endo. But I had no idea up until that point. But I was, obviously due to hormones fluctuating, nearing menopause, the pain was just horrific every month. So, but only for the last maybe 2 years. So I had no idea up until this point. So, and it was quite huge in there, wasn't it, Jason? There's
a lot of endometriosis,
yeah, really advanced.
But a good example of where not operating was potentially a good idea. So, and then Chloe, tell us about yourself.
Yeah, I had my surgery in 2021, where I was officially diagnosed, and then I've been working on myself ever since and done really good progress since then. So
we can get into that because you've done a lot of stuff other than the surgery.
Yes.
So a good case of where surgery is very helpful in some situations.
Yes.
Repeat surgery.
Just with the repeat surgeries, though, they can't ever become, illegal, can they? Because it comes back, doesn't it? It's not just one surgery and you're fixed forever, is it? You might have to have another surgery.
Is that something that would even be possible in terms of regulatory wise?
Well, yeah. Actually, behind the scenes, one of the things that we talk about is there was some really important points, some very brave women, some very brave clinicians that were whistleblowers, and then some very valid points with regard to that story. But the problem is there can be sometimes overreach and blowback that goes too far, right? And in obstetrics and gynecology, we're used to being heavily regulated. Caesarean sections were given a 20% completely arbitrary target. We were supposed to stop doing caesarean sections, so it has happened. Hysterectomy also comes into that discussion sometimes. The story around mesh was not good for prolapse. That's a whole nother podcast. But mesh used for urinary stress incontinence, bladder leakage, is very effective, and that baby got thrown out with the bath water. And we can get the feeling that maybe there's going to be a lot of babies thrown out with a lot of bath water with this. It has the potential to. So could it happen? Yeah, it's happened in other cases for O&G.
Yeah, I think we know endometriosis, and as you guys know, is a chronic condition and more of a chronic pain disorder. And so I think when many gynecologists who have an interest in endo learn to treat the disorder, we look at it and we develop a treatment plan with a lot of different treatment modalities. So surgery is one of those modalities, but physio, diet changes, different pain medications, different hormonal treatments can all form part of that toolkit to help manage endo for many women. And I think in some women, repeat surgery can be beneficial, but there is also, the way the Four Corners documentary was presented, it felt like it was saying that you should only do one surgery, and after the one surgery, then that's it. You're done. You need to manage the pain in some other way.
And we know there's situations when it doesn't work to just use hormones. If you're trying to fall pregnant, for example, and your pain is debilitating, you've tried your physio, you've tried lots of things, and you just get desperate. We know that can improve fertility rates. So there are certainly very valid situations.
I think there's many different kinds of endometriosis patients, and every woman's constellation of symptoms can be a little bit different. And there are some women who have a lot of other comorbid pain conditions. And doing repeat surgery in those women may not be helpful. It may be harmful. But as someone who's treated endo for many years now, I have learned that there's a subset of patients that do need a surgery every 5 years, when they're young, potentially when they're closer to menopause. It just depends on what their symptoms do, and then the surgery can provide relief.
But it's really important as well to understand that there are no guarantees, and that's one of the hard parts, that we know that some people don't get benefit from surgery, and patients have to have that prior knowledge that, it's not valid consent. If people don't understand, you may not get better from your surgery. It's a huge temptation to think that I've tried all these things. If I have surgery, it's very quickly going to go away. That's a quick intervention. It's going to happen on a day, and then the next day it's all going to be gone. But we know it doesn't work like that.
So endo is definitely moving towards, active management, meaning the patient has to be active. It requires dietary change, pelvic floor physio, exercise. Sometimes, when there's really treatment-resistant, serious chronic pain, acupuncture, ice baths, all kinds of things, that requires you to be active, whereas traditionally it's like, I want a pill, I want to lie there, have an operation, wake up and it's all fixed. And that doesn't work. So certainly, absolutely, the integrative multidisciplinary care model for endo is super important, and that's where it's headed, and that's what should be the gold standard. But it doesn't mean surgery is ineffective. Well, I guess rephrasing your question, maybe to Kelly and Helen and I, what circumstances would you think a repeat surgery is not necessarily a good idea? In what circumstances?
Yeah, so if I I see a lot of, again, chronic pain patients, endometriosis patients, and these women know what their endo pain feels like. When you sit down and talk to them, you guys know what that pain's like. You guys know that you may feel 2 or 3 different types of pain, and you can differentiate your bowel pain from your muscle spasm, from your bladder, from your endo pain. And so, like, say, for example, a woman's had 1 surgery and she's actually gotten pretty good relief of her pain from endo. And we check in, and a few years later, she comes back and is like, I did really good for a while. I've had a Mirena in, but my endo pain is starting to come back. Then you believe her, and you believe that perhaps then that that pain may benefit then from another surgery. But you also, during that consultation, take a really good pain history and, again, ask about bowel, ask about things like painful intercourse or stabbing rectal pain or bladder dysfunction, and then do a really good pain exam as well, just to see if there's anything else that may also simultaneously need to be treated. So you're not just focusing on, let's do a surgery and move on. It's not just not that simple.
For me, personally, like, I've been really sort of blown away by the fact that I can feel so many different kinds of pains. And I feel like I'm just so much more attuned to my body because of, and especially like when everything sort of ramped up for me about 2 years ago, I started with bladder pain and frequency and all of that. And all of a sudden I was like, have I forgotten how to live in my body? Like, what is different? And like mentally and emotionally, that took a huge toll too, because I spent almost a year doing all the other tests that come back normal and thinking, oh, I've just forgotten what it feels like to live in a body. Like, I thought it was all just in my head. So getting to where I have now, like, being able to tell the differences. And then fortunately for me, like, the surgery that we had validated most of those specific pains is exactly where we found it. So
validation is so important. So, like you mentioned that you found out for certain you had endometriosis with your surgery, and validating those symptoms, it's a very real thing that patients need.
And you're a great story of a good example of someone who's going to, I think, would be a good candidate for surgery. You've got serious pain. You've got endometriosis demonstrated on imaging. We really have tried everything else.
Yeah, I saw a dietitian, I saw a physio, I did all of that for about a year. And
medical hormonal management, and you still have severe pain. So when we do surgery, we hope and pray that you're going to be the one that comes back and says, this cured my pain. And we do get that. And then we also get people that come back and say at 6 weeks and at 6 months, this didn't make any difference. It's getting worse.
And you can't pick them, can you?
You just can't. If you could invent a blood test that would tell you who would respond and who wouldn't, I would love that technology, but it doesn't exist. So unfortunately, the landmark trial in 2004 by Jason Abbott, that was the double-blind control trial for endometriosis. There was a placebo group that got sham surgery, and then there was a group that got endometriosis surgery and had their endometriosis excised. And so the improvement for the women who had the surgery was 80%. So and in the placebo group, it was 36% of women. So 80 versus 36% got improvement in their pain, which is about right for placebo. Doesn't matter whether it's a drug or a surgery or whatever. There is some magical power of placebo, and it's always around about 30%. But the flip side of the 80% is 20%. 20% of women didn't get any improvement at 6 and 12 months, I think it was. And it was only a small study, but it's still the landmark trial. And I don't think it's 20. I don't know about you guys, but I think it's much less than that in my experience. It's definitely less than 20%. I'd say more closer to 5%. I feel would be the ones that say I didn't get any improvement at all. But we just, obviously we do the surgery wanting the absolute best, but we know there is that risk, and we put that into our consenting. Like, I think we all do that. We make sure people are aware and informed properly that we don't know if you're going to be that one. But more importantly, if you are that one, that's not the end of the road. We still have other pathways of investigation. We still have other treatment options. So I think it's really important for women to know that if you are in that cohort that doesn't improve after the surgery, then that old-fashioned idea of must be in your head, that literally that's what people would be told if they had endo surgery and they didn't get better. They would be told it must be in your. I mean, I've just heard that story so many times from ancient gynecology that doesn't happen anymore, because we have a lot of other tools at our disposal.
I wonder what the percentage is then of the people reporting no change, of the things you said you've done, Chloe, to also help yourself. I wonder how many of those patients reporting no change, I wonder what they're actually doing. Have they been educated enough to do all the other things to help yourself as well as the surgery, or maybe not? You know, it's hard to educate people, isn't it? Because a lot of people still do think I'll have surgery and that will be, everything's going to be great, but it isn't, is it? So I think you have to be hand in hand with all the other things you're trying to do, even if you do have the surgery.
And
sorry.
Oh yeah, I think what you're saying really highlights, if you're looking for an endometriosis doctor, that's part of what makes a good one, is they talk to you about the chronic nature of the disease, and they talk to you about all the other treatments. They're not just a surgeon who you're referred to, you go and you have surgery, and then they discharge you.
That was going to be one of my questions, actually, is something I found really hard when I was sort of starting to look into it is I read that many different bios of different gynecologists, and, you know, quite a lot of them might mention endometriosis, or they might mention pelvic conditions, but how do you differentiate? How do you know, what's the best way, I guess? Is there a way to know?
Do you want to start? You can start.
How to pick.
Or how to find an actual endometriosis specialist as opposed to perhaps other gynecologists that, they might be happy to do endometriosis surgery, but
or you might not get the level of treatment.
Because there's unfortunately not a separate specialty.
Exactly.
It's not a recognised subspecialty. That's the problem. So we have recognised subspecialties in gynecology, so gynae-oncology, urogynecology, bladder issues, IVF, COGU, which is ultrasound, and maternal fetal medicine, which is high-risk pregnancies and complex pregnancy issues. But it's still not a recognised subspecialty to do gynecology. And I guess there's pros and cons of that, because you don't want it being siloed away with one small group. It's a skill that I think most gynecologists have. So I think, it's a tricky one to answer, but I'd say look at the training, look at the volume, look at those sorts of things to determine whether someone is.
And ask. Yeah, ask.
I mean, I feel like the best way would be to go and ask, but I know for me, you're in that much pain, you're trying to find answers. You really don't have enough mental capacity to go and have 10 appointments and ask for those questions to every surgeon. So
I think trying to find someone who also has an interest in chronic pain is important, because those are going to be people who recognize that this is a condition that requires long-term management. Yeah. And they're going to have just that slightly deeper level of knowledge about what endo is, how it affects the body, and that type of thing moving forward.
Exactly.
Surgery for endo can be a really tricky one because women with very mild superficial endometriosis, that surgery is very easy, right? So most gynecologists can do that. But I think surgery for endo can quickly become incredibly complicated, like almost like a cancer surgery where it's attached to vital organs and blood vessels, and you have to have really deep knowledge of anatomy, dissection, that type of thing. And so you need to find a surgeon if you have severe disease that's experienced in that. And in that case, it would probably be sensible to find someone who focuses solely on gynecology.
And I think that's where ultrasound triaging and mapping is vital. So there's a lot of published data that shows that ultrasound is accurate at predicting stage, can be quite accurate. It's highly sensitive for deep infiltrating endometriosis of the rectum and the rectovaginal septum, which means a big operation. So first of all, it's because if you're going to go after all that endometriosis, you want to be in a team that has a colorectal surgeon and or potentially a urologist. You want to be prepared, but more importantly, you want to make a decision before the operation. Do I want to get that part of the endometriosis out? For example, is this for fertility? We occasionally have patients that have zero pain and stage 4 endometriosis. The bowel is glued to the back of the uterus. There's multiple nodules. That's going to require a bowel resection. Most gynecologists would agree. You want to optimize the pelvis from a fertility point of view, mobilize the ovaries, make sure the tubes are flushing, get out as much endometriosis as you can, because it's the inflammation of the endometriosis that's causing the subfertility. But you wouldn't necessarily go after the rectal lesion. So yeah, I think ultrasound triaging is really important, but it doesn't necessarily mean you have to have that surgeon because, like Kelly said, most gynecologists can look after mild, moderate disease.
So if patients understand that there is a risk that we could find something that is deep, even if it's not identified preoperatively, and sometimes the risk of doing something there and then outweighs the benefit of stopping, calling a colleague and having a discussion about, look, we can see what your symptoms are like and we could go back with that specialist surgeon, but taking high risks
and
without that
discussing it with a
knowledge.
colorectal surgeon before you even get into theatre. And another point you raised that was really important is there are pain specialists. Thierry Van Kai, who was in the Four Corners report, is a great example of someone who's a gynecologist, a surgeon, and a pain specialist. I am not a pain specialist. I can coordinate linking in with the pain specialist, but I'm a surgeon. I can coordinate with physios and nutritionists and other allied health like we have and optimize things medically with hormones and other management. And endometriosis is my favorite disease, as you guys know, but that doesn't make me a pain specialist. And equally importantly, endometriosis and pelvic pain are kind of two different things. So how much of your pain is coming from the endometriosis? So you can have a complex chronic pelvic pain, regional pain syndrome, and endometriosis is part of that. But I would say if the endo comes back, for example, someone's had 10 laparoscopies and you ask them, did you get any improvement in your pain from removing the endo 10 times? And they say no, that would be someone who I would not do another laparoscopy on. I'd say get a second opinion. If you're begging me to do it, I'm going to say no, get another opinion.
Because when you're at that point, you run the risk of pain. Your pain might seem similar to your endo pain, but perhaps it's coming from scar tissue or adhesions if you've had that many surgeries.
Pelvic floor, central sensitization, pain amplification from other comorbid conditions. For example, we're just not getting anywhere. We've literally done anything. Dig a little deeper. Maybe there's been sadly, some childhood sexual assault, some birth trauma, some other issue that's magnifying the pain. So that doesn't mean the pain is not real. It means we haven't been holistic and we haven't actually addressed, maybe we need to speak to a counsellor and optimize some of those issues as well, which cross over with pelvic floor spasm as well. So, yeah.
But I think even what you're saying, you demonstrate you have a high level of knowledge of chronic pain management, right, compared to, I think, many gynecologists.
Yep.
Right, who may do surgery Or they may just say, like, we've done your laparoscopy, I don't have anything else to offer you, I'm sorry. And so I think when you're a patient and you're trying to find a specialist, word of mouth is actually probably pretty important. Talk to patients about their experiences. And I think for something like pain, you need to be able to feel listened to, and you need to be able to ask questions, and you need to feel not rushed, and you need to feel your concerns are taken seriously.
And there's nothing wrong with a second opinion. I love it when my patients get a second opinion, because then it reassures me, it reassures them. There's absolutely nothing wrong with it. And we often get patients getting third, fourth, fifth. It's nice when we all agree.
Okay,
You're absolutely right. Yeah. About not feeling rushed though.
That's the big one too.
Honestly, I was my first appointment with Jason, I was in so long because he took so much time to explain. No, it was great though. I needed it. It explained everything. I walked out feeling like an expert. And if I'd have felt rushed at any point during there, it would have just, because I was in shock because I didn't know I had anything. So it was like, not feeling rushed is so
You're an
important.
expert in your pain.
Yeah, but nothing else. Until you told me what it was.
I definitely agree. I had seen another gynaecologist right before I sort of came across your event, and the stark differences between those two appointments were, total polar opposites. Like, I felt very rushed. Like, I'm a very organised person. I had a folder with all of my timeline and everything all printed out and ready. And the first appointment, the first appointment I had, they didn't even look at it. And just said that my symptoms were vague and I could get an exam if I wanted it, which is the total opposite. Like, before I'd already booked an ultrasound with Jason when I first came to see him. And before we even got that, he was like, well, you've definitely got something going on. So just totally different. So it's very important.
Yeah. And I think every patient also sort of knows, not every patient, but many come in to see me and they have sort of an idea of what they think is going on and what they think might be helpful. And so it's very useful to listen to that. Some patients come in and they don't want surgery, right? They just say, I have this pain, but I'm really fearful of surgery. I can't take the time off. I don't want the downtime. I just want to do anything else that I can, right? And so in those patients, exactly. But that's really valid. And other patients come in and they may have tried a pill and that didn't suit them, that type of thing. And they want surgery because they need to know what's going on. And, I think that's valid as well. So it's about listening to the patient and then coming to a treatment decision with them, with what we think is going to be the most benefit with the least amount of harm.
Yep. What you think and what is important to you and what you think the right treatment is very important. That's why we spend a lot of time asking.
I was just thinking about the four corners. A lot of women had surgeries to diagnose the endometriosis. Is that normal? Because we had a really big ultrasound and everything was there and you showed me everything and I was quite shocked at the number of surgeries.
Having said that, you would all remember me saying we can see deep infiltrating endometriosis with a sensitivity of about 90%, superficial, close to zero. We can sometimes see it, but it's not even really validated scientifically for us to be able to say that's superficial endo.
Okay.
So a negative scan does not rule out the disease. That's always written at the bottom of the report too. So definitely there is a role for diagnosis. You can do a laparoscopy to diagnose endometriosis and treat it at the same time if appropriate. Absolutely.
But it's not necessary for treatment. So plenty of treatment will be effective without surgery, as we've talked about. But
in terms of diagnosis, what is the gold standard? What makes it endo? Is it the histopathology report? Is it your symptoms? Is it what it looks like?
I think the pathology, is it?
That's what you would think.
Well, when you think about the definition of ectopic endometrial type tissue outside of the uterus, if we are removing tissue from outside of the uterus and it appears histologically the same as endometrial tissue, that's to me how I would logically explain that. but I'm sure there's huge variation in what constitutes, yes, this is.
Exactly, and from pathologist to pathologist, there's huge variation. In fact, when I was with George Condas, one of my mentors, one of the Brazilian guys, Rodrigo Rojas, was trying to put together a study at Delphi where he would basically try and get a consensus on what is endometriosis histopathologically. And he couldn't even get the study finished because no one was interested in it for a start across the world. So people don't really specialize in endometriosis histopathology. And from we found out one pathologist to the next has a completely different definition. So some pathologists, it's got to look exactly like endometrium. Some, it's got to be some glandular or some stromal cells. Some macrophages with hemosiderin in it, which I wouldn't think is endo at all. So there's a lot of heterogeneity, or there's no international expert consensus on what.
I was going to say, is there like a rule or
You would be surprised.
Yes or no.
You would be surprised. For lesions that are biopsied that look exactly like endometriosis, what percentage of them do you think the histopathologist usually says is endometriosis?
How it looks to you on ultrasound?
Yeah, so I think it's endo on ultrasound. It looks like endo, classic on laparoscopy. I send it off. What's the likelihood that the pathologist says that it's endo?
I want to say 70%.
Bang on, full marks
Really?
for Beck. So, and does that mean that the 30% are not endo?
No, I mean,
This is one of the things from that. So a lot of questions have come out about, well, hang on, my report here.
Took out all this tissue.
Correct. And again, we don't know the details of those individual cases. And if, and we didn't see the images that Thierry was looking at and saying this looks like there's no endo, and so that's a different story. But in a patient who's got severe symptoms, you do the laparoscopy, guided by your ultrasound. You take out tissue that looks, there's a saying, if it walks like a duck and it quacks like a duck, it's probably a duck.
And then staging becomes impossible because you can't predict what the histopathologist is going to say. So you might stage based on surgical findings, but then if you don't get confirmation at histopathology, what stage does that then?
ESHRA, the Europeans, and ACOG, the Americans, would say that actually laparoscopy is the gold standard. Now, 2022 guidelines would say, according to the Europeans, ultrasound is also the gold standard. So if you see it on ultrasound and if it walks and it quacks like a duck, then it is a duck. And the histopathology confirms it, but sometimes it doesn't confirm it. So why doesn't it confirm it? Because you've handed a burnt out carcass of a duck that's got diathermy marks, and so sometimes it says crush artifact, thermal artifact, and from your surgery and women watching or listening, you see your images of your endometriosis and you say, wow, there's a huge pelvic sidewall with spots of endometriosis throughout it, and you'd be surprised what that looks like when we hand it to the nurse. And
you and I were talking about that with mine, like
a little
it's so tiny once you cut it out.
So how's the pathologist? So it's very hard for them to see it sometimes. They might get sampling bias, so they've got a little crumb or even a big crumb, and they can't macroscopically see what's going on, so they take representative samples. What are the chances statistically they might miss it? So there's lots of reasons why sometimes we think it's a duck and we say it's a duck, but the histopathologist says I couldn't see a duck.
I think I had a good example like with mine. So both of my side walls had endo excised from them, and one of the tissue samples came back as endo and the other one didn't.
Yeah. Even though they both looked exactly the same, probably, right?
Yeah.
Or similar.
Yeah. So I think that shows a good example.
I think there were 5 samples and like 3 out of 5.
Only that one was the only one that didn't come back for endo out of however many we had.
It was a duck.
Definitely quacking.
Yeah, I think it's interesting.
But does it matter? What matters to me is, did it fix your pain? And so we're still, and if it didn't, then let's keep doing more and keep figuring it out. And also, if you come back in 10 years and the pain has come back, depending on how bad it is when it's come back, is surgery
Maybe we
a
look
good
again.
idea?
Yeah.
Maybe.
Yeah.
Definitely. But yeah.
But is it when is a repeat laparoscopy a good idea? I'd say when it worked really well the first time, and there's clear evidence that it's come back, and we have optimized everything else. I think a third, even a fourth, sometimes is appropriate.
Yeah.
And is time in
woman's a bit
between
different.
laparoscopies important in that decision too? Like obviously, rather than every year, if you had 3 over the space of 15 years, does that sort of give you a better chance of less adhesions and scar tissue issues? Or
I think so.
yeah,
The more surgeries you do, the greater the risks each time, and
And the
you'll
law of
get the
diminishing
biggest benefit
returns.
from the first.
Yeah, we know that and so a second, a third, the more times you do it, we know that it's never going to be as good as the first time. So which you have to factor into, is this the right decision? And I think that was a comment in the Four Corners article that all of us would totally agree with. Do it once and do it right. But maybe you can do it a second or third time given the right conditions. Yeah.
So what would be your thoughts on oophorectomy?
Yeah, when should you or shouldn't you?
Yeah.
If an oophorectomy is going to help their pain and the risks don't outweigh the benefits, like any disease,
So how do you make that judgment?
pretty much never take out ovaries. And you know, it's pretty rare to like. But there are situations. So if there's cancer, sometimes a very, very severe case of endometriosis surgically, it's almost impossible. And you say you're doing a planned hysterectomy. This sometimes happens, right? And you would in real time during the surgery be factoring in, have they finished having children? What's the age? Could we hormone replace if we need to? But sometimes there is an ovary that's so deeply plastered to the uterus that you can't safely get it out without causing a bowel injury, without causing a vascular injury. So sometimes the ovary it comes out, but it's exceedingly rare. I can think of maybe
And even rarer.
1 or 2 cases. But I've never had to do that, I don't think. What do you do in someone who's 25 and you've tried absolutely everything that you can and they are begging you to remove the ovary that they are certain is causing their pain? That's when I get a second opinion. And a third and a fourth and a fifth. I would just say, look, there's nothing wrong with this ovary. And there's a lot of data on the importance of keeping ovaries because they're very good for your bone density, cardio, and cerebrovascular health, and lots of other things. So ovaries are precious, absolutely. But we don't know the nuance of those stories, obviously. But there are situations where, if there's cancer in the ovary, if there's just no way to get a hysterectomy done without the ovary coming out, sometimes that's a rare situation. What other situations would you think of would be appropriate to remove an ovary?
For pain and endo. Yeah, those would be the big ones, I think.
Yeah.
And I mean, I think it may very well be the ovary causing the pain, right? When a woman comes in with pain, but it's hard to do a surgery. It's hard to justify doing a surgery and removing an important organ if you're not 100% guaranteed that their pain's going to get better with that ovary removed.
And what if they're suicide? What if they're like, I'm going to commit suicide if you don't remove this ovary? It's really tough. And also,
But you can do medical therapies that mimic taking the ovaries out, and I think
presumably you've done that already.
you would hope.
Also, just like you would never force someone to do surgery, you can't force people to take hormones either. There are a lot of women who get really bad side effects. They get depressed, again, to suicide, anxious. So sometimes hormones don't work for everyone. When they work and there's no side effects, awesome. No need for surgery.
Yeah. That's what I thought it would be good to sort of direct the conversation towards hormones, because they're such a huge part of endo management, and there's really strong feelings about them in the community and online. And I was just sort of curious as to what you guys had heard, or your experiences with hormone treatment, or what you had heard online in the endo groups and that type of thing about them.
Would you say you probably hear all the bad things and less of the good things? Like, do people generally say,
I'd say I've probably read more, like, you know, more often when you're in pain versus feeling really good, are you going to make a post in a group asking for help, right? So I feel like that alone is always,
Yes,
you know,
a bit of a bias,
or
yeah.
you're worried about the side effects, so you're going to make that post as opposed to your,
Hey,
you know,
everything's going great.
yeah, exactly. For me personally, I originally changed my pill from the one I'd been on since I was 18 to, I can't remember the name, but one of the sort of more expensive ones that were a bit different. That didn't do anything. And then once I'd sort of met with Jason and we decided to do surgery, I had to wait for my health fund to cover my surgery. So we had a bit of a planned wait.
Yeah.
And so I went on the Zoladex injections for that period of time. And that was the only thing that ever touched the sides of the pain. So
You told me that your surgery is going to be helpful. It's almost like a Zoladex can give you an insight. Okay, if you could just literally hit the endometriosis with the sledgehammer of Zoladex, which we can't do for a long time, it at least tells us we can achieve this by excising.
Thing for people to maybe, you know more that that's an option to do, because then before you go and put yourself through a surgery and your body through that first surgery, perhaps you can trial and see how you react if it's somewhat of a guide.
How did you feel on it?
I felt pretty good. I definitely got all of the hot flushes and the dry skin and sort of those things, which I was determined to put up with it for as long as I could for the benefit of wanting to just have as little estrogen in my body as possible and feel as good as I could. And then I think it was sort of coming into summer and I was like, I don't know how hot I want to feel through summer. So I started taking the add back estrogen tablets, which like got rid of the hot flushes, and I didn't really get a change in my pain, maybe a tiny bit, but not really. So I was still feeling like really quite good.
Nice.
And everyone's going to be different. So sometimes add back will flare some people's symptoms, but you know, it's, and the same thing that you have at one point in your life may not be the same at another stage. So, you know, before the surgery, after the surgery may be completely different. 10 years down the track may be very different. So ruling out a hormone because you've tried it before may not be appropriate, and it may be an option that you quickly close the door on when it could be helpful. So just thinking about things every time there's a change. What have we tried? What could we try? And not putting up with something not working for ages and ages, you know, because if something doesn't work for 3 months.
And if something's giving side effects for months and months, the good news is you stop it. Those side effects go away pretty quickly. So, and there are other options. And so we've got lots of tricks up our sleeve.
I had the Zoladex as well with 0 side effects.
Really? That's good.
And it shrunk everything quite dramatically.
Yeah. Excellent.
It's interesting that you mentioned that putting up with side effects for so long, because I was on a lot of different pills and was on the pill for like 4 years, different types all the time, just swapping between all of them because I was like, nah, not working. And then I had my first surgery and they said, well, you have evidence of endo, but it's all like scar tissue, like it's not really there. And that confused me quite a lot. That's why I went to Jason. But it kind of seemed like one of those pills was obviously doing something to like stop it or calm it. And even though it was giving me like pain relief and like helping me with all my symptoms, it just, it was also giving me a lot of side effects, which was...
It can make the disease inactive, but you can still have nerve damage from it and from the scarring and that type of thing, hey?
I think it's important to know that, it's annoying to, you know, have to just be so active on this stuff. But just because one doctor says try this one pill and it doesn't quite work for you, like it's frustrating to have to go back, but it's in your best interest to do so. And
eventually,
it's a lot of effort, but it's worth it once you find something that works.
And you want to make the surgery count too. And certainly we're never trying to coerce people into hormones, but you'll be hard pressed to find a gynaecologist that doesn't love marinas or pills. You know, so because we just know that they work, and we wish that there was more, but that's what we've got. That's, you know, and I spend a lot of time dispelling myths around the pill and talking about the safety of it. Nothing is perfectly safe, but the potential benefits outweigh the risks in most cases.
Hasn't it? Well, I didn't tell my mum about the Zoladex injections because I knew her era of people would be horrified. You know, it's come a long way. People my age and younger are very accepting of it now.
Yeah, absolutely.
Even something as simple as skipping your period on a pill was something that took a long time for me to help my mum understand that it was safe and that I was okay, because she was so concerned. That
You know why they brought in the placebo cycle on the pill? It was supposed to be taken continuously. When it was invented in the 60s, it was like, right, we can have contraception, we can treat pain and bleeding disorders, and so just take it continuously and don't have a period. But then a lot of women were thinking, well, where is my period going? Give us our period back. Doesn't it do something? It's supposed to flush me out. It's natural. Am I supposed to have my best explanation?
Is it just building up in there?
No, it's not going anywhere. It's because it didn't exist. We've suppressed it, and you don't need it, and it doesn't serve any purpose. And so you can choose to have that withdrawal bleed if it feels more natural, or you can choose to control your periods, and I think it does give women control.
Yeah, I ended up skipping mine out of, I wanted to avoid the pain that came with it. I didn't tell anyone that I was doing it. I just was like, well, let's see what this does. And I was like, oh, wow, okay,
Absolutely. Most women it worked well for.
But because I didn't know that you could or it was safe, it was very much a point of like, I don't know, shame, or I didn't talk about it. I just was like, oh, well, I can do this thing and can avoid that horrible time of the month. Maybe I'm being a wuss or whatnot, but I wish more people knew that,
I think if you've had that initial let's start the pill consultation, and maybe somebody hasn't had the time to sit and talk through why it's going to be beneficial, how you can use it, and it's not going to necessarily hide things while they're getting worse behind the scenes. And it's a legitimate treatment. Just spending that bit more time really makes a big difference and makes it potentially.
You generally just get given a script and take it as directed, and that's that. And you don't get given any more information. And as an 18-year-old, when I went on the pill, I really wish that everyone got more info at that point, because it's such an important
you sit
time
there
of your
reading
life.
the pamphlet going, what am I actually taking?
Never read the pamphlet. No, read it.
And then you might get told something different in the pharmacy as well.
It's a shame we don't have a great cure for endo, hey? Like we have all these treatments that may work and they may not, or they may have side effects and they may not.
I find it so frustrating how individual every person is. That's one thing that's frustrated me a lot. Yes, this may work, but it also may not.
I know.
In every single conversation you have about it, and it's really
A
frustrating.
lot doesn't make sense about endo. Why can you get stage 4 and not have any symptoms until perimenopause? Or why could someone have superficial disease, some freckles, and excruciating, and treating that actually alleviates it along with other treatments. So I think we're in an interesting time in endometriosis. In the past, we've come a long way from, and we've still got a long way to go, but those delayed diagnoses, the gaslighting, the as a male gynecologist, it just blows my mind how much women can put up with. If men had to put up with even ovulation, I think we'd be in ED every month. So coming from there wasn't as much known about endometriosis. There's still a lot more we don't know. But look, I went to the World Endometriosis Society conference last year, and it's a great conference because you're sitting with surgeons and colleagues, but you're also sitting with researchers. And
that must be amazing for you.
Then you can see the future, right? So most of it goes over my head, and I'm not as smart as them, but it just blows my mind. So that some of the genotyping of endometriosis. So we talk about stage now and morphology, and it's like, well, there's deep and there's superficial and there's endometriomas, and that's the three things. And there's so much wrong with that argument. Maybe we could get into, but I think endometriosis will be genotyped. They're looking at, say, the DNA expression in individual lesions. There's sort of 5 subgroups of that. So some of it expresses fibrosis or scarring. Some of it expresses angiogenesis or making blood vessels, sometimes neurogenesis. So literally they show these slides of they've created animal models and then developed endometriosis in rabbits or rats, and then they figure out what the gene expression is. And they show you these lesions with nerves growing out of them, and that's the same as what's happening in the lesions in humans. And it's like, oh my God, these people don't get out much. But they are brilliant.
Target therapies, right? Like
Yeah.
cancer, right?
Once you look at
yeah,
the gene.
exactly, and they can say, well, this
I think I've
person is
read
going to
or
benefit from
seen
this
as
therapy.
well some research or discussion around endo being part of like an autoimmune
Exactly.
condition as well,
Yeah,
which I find
exactly.
really interesting.
Autoimmune, inflammatory.
You open up a lot of treatment, right, when you
absolutely.
once you know that's what
yeah,
it is.
absolutely.
Yeah.
So I think it'll be subgrouped into the gene expression, the inflammatory marker expression, the DNA mutations. So there's some DNA mutations in endo that are also common in cancer tissue, and the sort of genomics, the way DNA is handled, and from where it's headed, it's, I think we'll end up with, there might be 5 or 6 or 7 subgroups, and you'll be able to take a biopsy rather than have to do full excisional surgery, take a biopsy of the endo or multiple biopsies, and you'll be able to type it, and then there'll be targeted medical treatments depending on which type of endo you've got. And exactly, if you can do that with cancer, why can't you do it with endo? So there's like, molecular and immunotherapies for cancer, and you can literally, like BRAF inhibitors for melanoma, you can just melt it, and then there's no need for surgery. And then the poor old Jason, Helen and Kelly will start a sports bar on Man Street. We've already talked about we'll be fine. But yeah, it would be fantastic.
You just need
So
the money and the interest, right?
correct. And but the other thing is, a lot of the discussion is, well, what's superficial and what's deep, and how is it staged? And just like the histopathology argument, you would be surprised how little we know and how much difference from inner observer variability there is, meaning you show 100 different gynecologists the same picture of endo, and we'll be all over the place in what's deep and what's superficial. Like, is there a definition? You can say, yes, superficial means it's superficial and deep means it's below that layer, but how do you even determine that? Some papers have said it's got to be more than 5 millimeters depth, and that's completely arbitrary and no one really knows. I mean, personally, I think surgically, if you pick up the peritoneum and it lifts up and you can get under it and it dissects away easily, and you can see on top and underneath that it's clearly confined to the to the peritoneum, then it's superficial. And if it's stuck to the stuff below, then it's deep. But that's just my definition. There is a 2021 international consensus across a lot of the big groups, AAGL and ESHRE and a couple others, CanSage, and they talk about it being superficial or deep or endometriomas, and that's echoed in some of the Australian guidelines, and that was mentioned in the Four Corners report. There was also an argument, well, we shouldn't actually operate on superficial, but how can we even decide if it's superficial without removing it? In some cases, it's impossible to tell. And who decides if it's superficial? The peritoneum, where it lives and where it starts, is literally one cell layer thick. And so, I mean, we don't know if it starts off as superficial and then becomes deep. So if you go to the trouble of having surgery and remove all the stuff that you think looks deep and stay away from the stuff that's superficial, then was that actually going to turn into deep?
Then if you can also have people that have just superficial and have pain, is that not a good enough argument to remove it?
Absolutely.
If it can
Because those are
cause
women
pain
who
on its own.
clinically, in my experience, those are the women who have the worst pain, are the ones who have just a few, they look like little blisters,
Yeah.
but they're really active and they're really
And they can be widespread as well. Yeah. And what is the evidence for the comment that we should be moving away from excising superficial disease? There's not good evidence for that. Yeah, that's the point. There's an absence of evidence. So there are a couple of trials in progress. There's one in the University of Edinburgh, Scott Mackenzie, I think it is, a big group, and they're doing a huge RCT, and they are directly comparing superficial and deep. Again, I'd be interesting to see how they define it, because it's very tricky. But I think that might give us an answer, and maybe it will say superficial disease doesn't improve in the same way that deep disease improves when you excise it. Maybe it won't, but currently we don't have that evidence. There's the Cochrane review from 2020 that looked at does surgery for endometriosis work or not, concluded there's not enough evidence. There's 14 trials, 1,500 women, pile all those trials together, and it's not good enough quality. So that's why I mentioned that that landmark trial by Jason Abbott in 2004, I think it was, that showed that there was improvement, but it was a very small study, 39 women. You need a big study. And all we can go on is the best available evidence. And in the absence of evidence, that includes our shared knowledge and wisdom and experience of excising disease and seeing that it does help a lot of women, and some women it doesn't.
We talk to each other, we listen to patients, right? Like, what do you guys think would help? Like just in general with treatment of endo, like is there anything in terms of system issues, government support, like anything that people should understand better? Like, I know that's a very broad question.
Yeah, well, it's expensive, isn't it? It is expensive to.
Absolutely.
But even surgery, like, you know, I don't know what the figures are, but it seems that to get a proper endo specialist, they're not in the public system. You're going to have to go private. And I've got a couple of friends that have had surgery through the public system. And whilst getting very little information out of their surgeons on what they saw, they were sort of, the two that I know of were told, oh, you had like one little bit, and are still in heaps of pain. So it's been, it has been something that like me and my partner have gone through, talking about how, we're going to have to spend the money because unfortunately it doesn't really seem accessible otherwise.
It is, like it's very expensive, and the alternative is that the surgery is available through the public system, but pain is not considered a priority, and so women are then subject to the wait. And they're
Sometimes changing their planned surgeon.
absolutely and they may not have control over whether their surgeon actually is experienced in endo or not.
And then it becomes very endocentric, surgery-centric management because it's tougher in the public. You just don't have that comprehensive wraparound service.
And because it's not its own subspecialty, right? You're at the will of getting anyone in that huge pool of surgeons.
I think around the world there's been a push to develop the endometriosis centers, which is probably great for managing endo. So you have the surgeons, you have the sonographers, dietitians, all of the allied health specialties in one place. But
And urology and colorectal and all the
in reality, though, the demand is so high. You know, if 1 out of 7 women has endometriosis, and these endometriosis surgery centers may only be in big cities in certain countries, right? Like it's not accessible to so many women.
And as soon as you say, you know, this person is the specialist and this is the only person you should go to, all of a sudden that destroys access, because we do know general practitioners can manage endo. If you start the pill and it works, then you're done. You know, generalists, obstetricians and gynecologists, and every level of experienced endosurgeon in between can manage endo at different levels. So not everyone needs to. Not even everyone needs that level. And if we think that they do, then we're going to have a big traffic jam. It's going to be a problem. So
even things like, you know, the care plans you can get with Medicare. You know, I ran out of those long ago between my physio and my dietitian. Like it's, I don't know what it is. I think it's maybe 10 in a 12-month period. But if you're seeing, there you go.
That's it.
So if you're seeing a dietitian and a physio and maybe acupuncture, which I'm doing as well, like, you know, it's not enough. And even when you do get it covered, you've still got a decent gap. So
if you could wave a magic wand and have any, you know, some new technology, some new tool or some funding for some project in endometriosis, what would you, Chloe, do you have any?
I would say a really like easy diagnosis tool, tool, something like an X-ray or something to be like, and it brights up in lights.
You
that
mean
would
like
be
an
so
ultrasound?
cool. Yeah.
It's a sort of dye, right? Like you put a
Yeah.
dye in and it goes and it just like
Yeah.
PET scans.
Blood test.
Like a PET scan.
That would be
Yeah.
cool.
I think imaging augmented by, there's always new, every time you go to a conference, there's like 1,000 new, we've come up with the swab or the blood test. And
Yeah.
none of them ever really work out that sensitive or specific enough to be useful. But I think eventually we'll probably have that combo.
Because I mean, the ultrasounds are amazing, but at the same time, I know personally they're extremely painful to go through. So one step again is something that's more accessible and doesn't cause a lot of pain, like more pain for you.
And there are very few people that are actually properly trained in doing the scan.
Yeah.
So again, that's not nearly enough to meet the demand of the population, right?
That would be my wish. More people like you three that have chosen to specialise in endo. We're so lucky because it just wasn't a thing, was it?
Yeah.
A long time ago, and you've chosen to specialise in it. I mean, that's amazing. That's incredible.
It's important, but you can make a big difference. I remember something that really made a big impression on me was looking at this graph of a trajectory of a woman's life with endo and without endo. And so there's a big difference in what a woman can achieve if she's diagnosed early or doesn't have the disease, compared with someone who struggles with pain their whole life. So they start in adolescence, they start missing school, they get behind in school, their relationships struggle, their employability struggles, their job opportunities change. And by getting on top of endo early and
Leaving those adolescents who are coming in saying, I just can't get to school.
But you make a massive difference in the trajectory of someone's life, right?
And then pain overall and pain coming from anything is going to impact every single part of a person's life, no matter who they
relationships,
are. So,
family, kids, everything, right?
Health.
Absolutely.
I think we're getting better at early intervention, and I think we're getting better at early diagnosis. Ultrasound is invasive, transvaginal ultrasound is invasive, but it's not as invasive as surgery. So we're getting a bit better at diagnosis, but we're also getting better at that validation in terms of, I think, if I could have a magic wand, it would be just, we could even just get into schools and educate girls, even when they start having periods. Just be on the lookout for these things and don't think that you're crazy and don't put up with it. Ask to see your GP, ask to see a gynaecologist.
like a proper overview of what a normal pain
symptoms.
level is, because and trying to maybe relate that back to something else that everyone can experience, because I only very recently, was talking to someone and they said, oh, yeah, maybe on like day 3 of my period, I might need a Panadol.
Yeah.
What?
I've never had that before.
That's real?
You get the fertility patient, no, I don't have any pain, I'm here because work up for IVF, just want to check there's no other reversible causes, endometriosis, we know there's evidence, remove it, makes fertility better. But they're saying, well, no, I don't have any pain, so you've got silent endometriosis. Of all the women that have silent endometriosis, I usually still ask them all the questions. Yeah, so you're silent endometriosis for 2 days out of the month, you're curled up in a ball and can't leave the house. You have blood in your stool and like 10 out of 10 excruciating pain when you open your bowels. You look 40 weeks pregnant with bloating when you have a period, and you don't enjoy sex because it's excruciating. Not quite silent. So retrospectively, it's just like that the pain gets normalized.
I think trying to educate at the point of when you learn what is normal is good.
We might not be able to make it 0, but we definitely can, make it better.
Yeah. That's that long wait between like when you first start getting symptoms and then you trying to work out what it is, and it's that long progressive wait, and then you get the validation. You're like, okay, cool, now I know. Yeah. Now I can move on. Now I can work on this, because now I know what's caused.
Yeah. But it takes a long time during really important years of your life, right?
Yeah.
Especially, that was me in all my teens. Yeah. So just trying to work out what's going on. Why am I doing this? What's happening? And then finally, yay.
And realizing that, at the age of like 13, crying in the shower, not wanting to go to school because of the pain isn't normal. But, you know, unfortunately, I have a suspicion that perhaps like my mum probably has it too, because she's always had, like I've got adenomyosis as well.
Yeah.
And she's always had heavy, like she was fainting, she was like had iron deficiency problems, but that's the person who then teaches you what is
What's
or isn't normal.
Yes, exactly. Yeah.
So,
It's very
yeah.
generational.
Yeah.
A different type of generational trauma, right?
Yeah, yeah. And it's, you know, your mum going, yeah, I know it hurts. Get up, go to school.
Yeah.
It's like,
Yeah.
yeah. And it's very hard to unlearn that once you've learned that.
So we have come a long way in that, Chloe, before you got your diagnosis, how many appointments did you go to? So we can go to Jason or other people now, a one-stop shop, ultrasound, I've got pain, let's do an ultrasound. Pretty sure you've got endo. That's great, isn't it?
And you know that everyone in that building is specialised and does 100% know about it, because, you know, like surgeons or your other allied health as well, some physios won't know as much as others about endo, and all of that as well makes a difference.
I think it's important for women to know that they can ask to see a gynecologist. Like, I think we have a lot of fantastic GPs on the coast, and I think when many women come to me, the GP has already trialed many things, right, to manage. Like, they've done amazingly. Yeah, but every once in a while, you do get women come through who say, like, I've asked to see a gynecologist, and I've been told, no, you don't need to, that type of thing. And they can always ask, right? Just say, I prefer to see a gynecologist for this, and come
The need
and
to
chat
get a
about it.
referral to even come and have an appointment with a gynecologist is probably a problem with the system too.
Yeah, true.
Because that's,
very
you know,
true.
that is then dependent on the GP just deciding that they agree or not,
Yes.
which I think is silly.
Yep.
Good call.
Absolutely.
Yeah.
Did any of you, the three of you, have any other specific questions that you can think of that were raised by that that episode, or anything else that you want to ask us?
I've just got one. From the documentary, if you were doing a surgery and you realised at that point, you hadn't realised until you were doing the surgery that an ovary needed to come out, do you do it there and then, or do you finish the surgery, have a chat with the patient, and then do it? Or do you...
You can always go back, I think, when it comes to ovaries, but then, you know, the really important thing when it comes to endo is individualized, right? So what if this person has really bad Crohn's disease and they've had 3 midline laparotomies and it was almost impossible to get to the pelvis, and they're 54 years of age, and they're not planning on having any children in the future, and I can see, you know, maybe a huge endometrioma on one ovary, and it's plastered to the pelvic side wall, and I'm going to have to try and dissect it off. You know, they've got another healthy ovary on the other side. Individualize the situation. You know, that ovary I would remove. I think. I don't know. Would you go?
Yeah, in my mind, it's really different when a woman is in her later reproductive years. I would have a lower threshold for doing it if, again, it's an unusual situation, but the ovary would have to be very abnormal. And I would have to think that I wasn't doing the woman any harm, that I was doing her benefit by taking the ovary. Generally, in a younger woman who hadn't had children or hadn't completed her family, you'd never take an ovary unless it was cancer.
Right, okay.
And again, there's always the exception to the rule, but that generally speaking, that would be how most gynecologists would approach things.
And what about hysterectomy? If I just replace the word oophorectomy, meaning removing the ovary, with hysterectomy, meaning removing the uterus, I guess what would be a situation where I wouldn't remove a uterus? Helen?
So I wouldn't remove a uterus unless I've talked to the patient in advance, unless it was life-threatening. No, you know, it's got to be something really life-threatening and an active choice.
But even in consenting for someone, so someone says, I want my uterus out, I'm done with it, and they're 21.
That's a hard decision, and really,
I'm not going to have any children. I've already Like,
I don't think that's a decision one clinician should make on their own. That's got to be involving multiple clinicians, including someone who knows the patient really well and someone who has interacted with them for a long time. So, you know, their GP.
it's a team sport, right? Yeah, I think there's that. Yeah, I think in those very rare situations, mostly I feel like if I'm saying no to surgery, I'm always gonna, or if I'm even not sure, if I'm not sure, then I think I'm gonna refer them to you guys and say, what do you think? And then if they've been to 5 gynecologists and they say, well, I don't really think that you should have this hysterectomy, then I think, we've got to just keep following those non-surgical pathways for that
But keep
person.
reiterating the alternatives, because there are plenty to try. And if you've tried them, that's a very different situation to if you haven't tried any, and making sure people are aware of the options.
Have we done hysterectomies in people in their 20s? I have. I don't know about you guys, but I can think it's someone that's had 5 children, has already had their tubes removed, is in excruciating pain, and there is a clear pathology, and it's in the uterus, and we've tried medical, or they didn't. Actually, I think didn't want to have a marina, didn't like the idea of having a foreign body, had too many side effects from the pill.
Yeah.
Individualized.
It's all individualized.
I do have
You
a
can ask
question
anything.
regarding, like, as a patient perspective, what should you know going into surgery and what should you know coming out of surgery? Like, as a patient.
Awesome question. What do you think what do you think? And what did we give you? Was it enough? Did we miss anything?
Well, I found it was great, like very informative on what exactly is going to be happening, what is still up in the air until you go in and have a look. But a lot of people don't know and are not given that kind of care to be like, oh, well, how much will I know and how much coming out should I be reading the reports, the pathology reports after?
I think if you're told the surgery is going to fix everything, then you should question that.
You should be able to trust your surgeon if they're and ask them to see it with them. So I'll often have the report on the screen and we go through it together and we look at images together and we're clear, like, I'm going to show you this, but do you understand what we're looking at? Because you understanding your disease is so important.
I think you need guidance when you look at that histopath report and when you look at the intraoperative images and the operation report. You should get all 3. I think it's pretty standard practice that you would always give the op report, the histopathology and the images. That's your information. But you do need some guidance to debrief. So I would never want to...
It's perfectly valid to ask for it, but at the same time, you need that support to just... There's plenty of words that we wouldn't expect you to understand.
I think in terms of recovery, it's also important to understand realistically what to expect in the weeks after surgery, because everyone's experience is a little bit different. Some women have, like, their pains improve pretty quickly, they bounce back, they're back at their normal activities within a week or so, whereas many women have a longer recovery. They have a few weeks, 4 weeks, or they wake up and they're actually in quite a bit of pain because... because you've done a lot of dissection, or you've taken a lot of that sensitive peritoneal tissue out, and that's got to regenerate and it's got to heal, and they're going to be sore while it heals. And we can give pain management, obviously, but I think it's important to set that expectation that even though it's a keyhole surgery, it's a day-only procedure, what we do inside can actually be pretty major in terms of dissection.
I think that's a really big sort of misconception. Even, just talking to people, and they go, oh, so how big's the scar? You've had this big surgery, you've been off work for like weeks, how big's the scar? And then you say, oh, it was keyhole, like it was laparoscopic. And they're like, oh, okay. And then they just think, okay. And they, exactly. So I think that's really important for people to understand that just because it doesn't require a big open incision doesn't necessarily,
I feel like we almost probably go we have to, but we almost go too far with warning you about this is going to be a tough recovery. It's going to take this long. You might not get any improvement. You might get worse. You could get a hole in the bowel. You could get septic. We have to. Obviously we give all the stats, you guys know, but we sort of have to do that. But it's it's pretty heavy when you're consenting for surgery, but it realistically has to be. And then I agree. Like you could have the same patient on the same day, have the same pathology, and have an identical operation. And one of them, I've had a lady like 1 week after a hysterectomy doing a 40K hike. I don't know how on earth she did it. And it's almost identical, still in a lot of pain and having issues like 8 weeks later, and thinking like, does Nick Riviera has operated on me, or who is this guy?
But it also doesn't mean...
Everyone's different.
Well, I was going to say that it's not just that one person can handle pain and one can't, right?
No.
It's actually the fact that people react differently. Because sometimes I've found that's hard because you go, well, does everyone else just get on with this level of pain? Or
Yeah.
It's hard to know when you're in that moment, I think.
Yep, exactly. But yeah, everyone's different, so.
Yes. And all the pathology is very different. And the response is different.
Makes it interesting, right? We're not bored.
We're not robots.
Yeah.
We are.
Very different,
Yep. You're all unique creations.
You can't select people that read your pathology, or you can't select the person. It's just potluck.
The pathologists are great. It sounds like I'm slagging off on them.
But yeah, different gynecologists.
Yeah, if you want 100 different opinions, ask 100 different gynecologists.
Yeah, heaps of different.
On the big questions, I think we agree.
Yeah.
But yeah, well, thanks so much for joining us, and I hope hopefully that has helped you guys kind of get your heads around some of the concepts of endo. I hope endometriosis sufferers and their friends and families get something out of this roundtable, and you can never talk too much about it. Which is why we wanted to do this tonight, because it was a big grenade that went off in the world of endometriosis and gynecology, and a lot of people have run and ducked for cover and don't know really what to say about it. So I think the more we talk about it and keep the conversation going, the better.